Welcome to this podcast, which is about the knee joint. The first thing we're going to do is talk about the bones. So we have a femur proximally and a tibia distally. The femur ends in two condyles, a medial and lateral one, and the tibia fans out into a plateau. We also have a fibula, which is lower down on the lateral side of the leg. So we've got three bones that make up the knee joint and the patella at the front. We need to control lateral movements in the knee because this is a major stress in the knee. Everyday activities put a lot of varus and valgus strain, so we need two collateral ligaments first of all. So we have a medial and a lateral one. We have two strong collaterals that come from the medial and lateral epicondyles and go to the head of the fibula and the shaft of the tibia. They're called the medial and lateral collateral ligaments. We have two fibrocartilaginous discs that sit inside the knee, which we'll talk about in a few moments. And at the front we have a sesamoid bone, the patella, which is actually embedded inside the quadriceps mechanism itself. We take the patella off, we have two ligaments inside the joint, two cruciates, an anterior and a posterior cruciate ligament. If we look at the knee from the side, you might think that the femoral condyles are round, but they're actually not. They've got different radiuses of curvature, which we'll talk about later. The knee joint is covered in articular cartilage, like most other joints, the femur and the tibia. We also have an extra layer, these fibrocartilaginous discs called menisci. And here I've tried to show you the position of one of the collateral ligaments from the side. We have a patella at the anterior of the knee, and we have two cruciates, and that little spot at the back is a bone called a fibella. So the four ligaments, I'm drawing them on here. Here's the femur, here's the tibia, the tibial spines. We have cruciate ligaments inside the knee, an anterior and a posterior cruciate. We have a medial collateral ligament, and we have a lateral collateral ligament, which actually goes to the head of the fibula. And they are the four main ligaments in the knee. From the side, one of the roles of the cruciates, apart from a proprioceptive role, which is very important, is to limit anterior and posterior translation of the femur on the tibia or the tibia on the femur. The reason we need a patella is not a shock absorber, as most people think. It will absorb shock to a degree. If you don't have a patella, here's the femur, here's the tibia. This is the angle that the patella tendon would attack. That is rubbish. So if we put a pulley in the way, femur, tibia, patella, that gives the quadriceps a greater mechanical advantage. And yes, I'm left-handed, so that's why my tick goes backwards. The patella normally sits in a little channel between the femoral condyles. The patella is joined to the tibia by the patella tendon, which attaches to the tibial tuberosity. You'll come across patients with a condition called Osgood-Schlatter's disease. This is an X-ray of a young person. You can see the growth plates, and you can see epiphysitis at the growth plate of the patella tendon, tibial tuberosity. The knee is not a hinge joint, it's a modified hinge joint. You can rotate it as well in a flex position. It's also not just a straightforward hinge joint, it's got different radii of curvatures in the femoral condyles as well, and there are gender differences between males and females. So a female tends to have a wider pelvis than a male, and that has the effect of changing the angle of the knee and giving them what's called a different Q angle. So here's a typical male pelvis, exaggerated of course. Here's a typical female pelvis, so you can see that the angle of the knee is slightly different in females. There's a thing called a Q angle. So if we draw the knee, if we draw the patella, if we make crosshairs over the middle of the patella and then draw a line going towards the ASIS, that angle is called the Q angle. If the Q angle is too great or too small, it can affect the biomechanics of the knee. And that might be one of the reasons why ACL injuries are commoner in women than men. These are the menisci sat on the tibial plateau. You'll notice they aren't the same shape. One's more round and one's a more C-shape. They're bound down to the tibia by things called coronary ligaments. The inner aspect is mobile, it actually moves. So I've got a picture of what a meniscus looks like here through an arthroscope. So you can see here the femur at the top, the meniscus in the middle, the metal thing is a probe, and there's tibia, the cartilage on the tibia that the probe is actually pressing into at the moment. Here's an MRI. This is to show you that the menisci aren't really shock absorbers. They will shock absorb to a degree, but they're actually there to make the bones fit together better, to increase the congruency of the bones. You will come across patients with torn menisci, and there are two common types. There's a radial tear and what's called a bucket handle tear, which I've drawn here. And obviously the fragment can flap up and down like the handle on a bucket. Acl injuries are very common, can be caused by flexion and rotation combined, or hyperflexion, hyperextension. One of the diagnostic indicators is an immediate swelling, so it's called a hemarthrosis. This is a person with bleeding into a joint. You'll also come across knee replacements. Here's an X-ray of a knee replacement. One of the things that's important in the knee is when we are stood, the flat part of the femoral condyle is in contact with the tibia, so it's stable. But when we flex, it's the rounded part, so we're inherently unstable when we flex our knee. And I hope you found that useful.